edition of Virtual Morning Report with RLR, where I might have to stand in for both R's. We'll see if Reza can join us today. If not, we'll still fly along and continue this morning, because we actually have a very, very, very special presenter today who reached out to our the biggest celebrity here, student Dr. Rafa. No, yeah, he's hiding. Yeah, so we're all discussing Rafa's celebrity status on Twitter now. But that is a topic for another day. We're graced by Andrea, who has a really, really amazing case to present to us. Andrea, do you want to unmute and introduce yourself?
Hi, I'm sorry, my camera is not working.
Oh, no problem at all.
I'm Andrea Perdigão. You may call me Andy, it's easier. I'm a med student in Brazil, and Rafa's an angel. I told him I had a case, but the case was not good, and then he gave me one, and it's amazing. You guys are gonna love it.
I love it. That sounds wonderful. Rafa is indeed an angel. I will endorse that. Even though my tendency is to get under his skin, today I will just pat him on the back. And Andrea, I think one thing that we're all learning is how important it is to truly learn how to say people's names the way they are, because it's your name, it's your identity. And so while it might be easier for some people, depending on what their native language is to say Andy, I'm curious if you can say your name one more time so I can learn it.
It's Andrea.
Andrea. Okay. All right. Well, if I mess up, keep correcting me, and I promise I will learn.
Okay.
All right. Oh wow. I think Prof. Rez is here. I can't tell. Where is he? One sec, folks. Okay, all right. I think he's joining. Prof. Rez, if you're here, say hello.
Hello, hello, hello.
There you are. What's up, good sir? Long time no see.
How are you guys? Just here in the coffee shop. Got the croissant, got the black coffee, and ready to discuss some medicine.
Amazing, amazing. Well, we're joined by our dear friend who connected to Rafa, Andrea, who is going to be presenting a really cool case to us. So Andrea, kick it away, and I'll let Prof. Rez imbue the coffee shop magic and teach us.
Okay, let's get started. Just a second. Okay, first alquat. A 61-year-old male patient presents with pruritus. That's the end of the first alquat.
Andrea, thank you so much. It's very nice to meet you. And Anne-Marie, can you hear me okay? I just want to make sure through this mask that my voice is coming through.
I can hear.
Okay,
can wonderful. You guys hear me?
Yes, totally. I just wanted to make sure everyone could hear me. So the complaint we have is pruritus. I think what's really important is to remember, whenever you're solving a problem, you need to know the who, the when, the what. All we have here right now is the what, which is pruritus. Once we flush out the who and the when, the temporal, then we can make much more progress. So all I'm going to say at this stage is when you're approaching pruritus, the first branch point is whether it's acute or chronic. And the second branch point is whether there's a problem with the skin or something internal that's driving the pruritus. So I'll leave it at that because these two have completely different differential diagnoses. But as we get more information, I'll be looking at the time course, and I'll be looking at whether the primary problem is the skin, like dry skin or scabies, or if it's something internal like thyroid disease or liver disease.
Really nice. I think I have some answers. Here in the second alquat, I have the history of the present illness, and it is 1 month ago, the patient began to feel itchy after mowing his lawn. He says he does it frequently and never had this problem before. Initially, his pruritus was limited to his upper body and upper extremities, but eventually progressed to his scalp and face. There is no relief with topical diphenhydramine. He went to his primary care physician, and he was noted that he had scattered scoriations on his chest and back, but otherwise no abnormal findings. He was started on prednisone for possible allergic reaction of unclear etiology. On follow-up with his primary care doctor, the patient reported initial improvement, but re-exacerbation without trigger and additional gastric reflux symptoms with acidic taste on his mouth. So the primary care physician trialed him on cyproheptadine and famotidine, and the patient's symptoms did not improve. So he presented to ED, and that's the end of the second alquat.
Excellent presentation, my friend. Andrea, can I ask you, how does it feel to present?
It's scary, but it's
Yeah.
awesome.
Why do you think it's scary? What makes it scary?
I don't know. I think, honestly, basic the language, because English is not my first language, and I got a little nervous if I say something wrong.
Yeah. I have to tell you, I think your English is outstanding and very easy to follow, especially for, more importantly, for our first ever scribe, Katerina, scribing for the first time. And you can see how effortless it is for her to keep up with you, probably both reflecting your skill and hers. But if I keep talking, I think people are just going to start to get itchy and annoyed. So let's tackle this itch instead. And I think Prof. Rez's outline is serving us very well here, because we're learning that this is more chronic, and we're learning that it is diffuse and disseminated. And I just wanted to point out how important it is to pay very close attention to the words that the patient is using. The patient isn't saying that he has a rash that is itchy. The patient is saying that it is an itch that's the primary problem. So when you're solving pruritus, you want to know, one, the answer to a key question. This is the crux of this case. Is this a rash that is itchy? Or is this an itch that rashes because of scratching? That's the key question. And answering that question will take us down to either a primary dermatological issue with prominent pruritus, or will take us down a systemic cause of pruritus that the patient scratches getting a rash. So in a case of pruritus, the key question is this a rash that is itchy, or is this an itch that rashes? And here the chronology of events prioritizes an itch that rashes. And so the question is, what is the most common cause of a rash negative pruritus? And how do we approach that? And I will tell you, you're going to be humbled by the most common cause. It's patients having a subtle rash. And Jorge just said that. It's when patients have dry skin. Xerostomia is by far and away, xerosis, excuse me, is by far and away the most common cause of an itch that rashes. And it's because the skin is so dry, it gets itchy, and then you develop a rash. After that, there's medications that can do it, most notoriously opiates, neurological conditions like notalgia paresthetica, and psychiatric conditions such as delusional parasitosis. Those are by far and away those four most common ones: dry skin, medications, neurological diseases, and psychiatric diseases. And so the initial screen should involve those, followed by an analysis of things that are maybe more morbid than these four common but less morbid conditions. So I'll pass the mic to Prof. Rest, what crossed his mind in general, and what his additional layer of morbidity would have us think about in this case.
Robbie, I think it's just quite poetic. An itch that rashes, or a rash that itches. That should be the title of this case. And I'm right there with you. And the approach I take is one, considering chronic diseases and also considering pathology of three organs: liver, kidney, thyroid. So pathology of these three organs, liver, kidney, thyroid. And it's really important to come up with a DDX because that will prompt the next step. So I want liver chemistry test with a specific focus on the alkalis and the bilirubin. You want a renal panel to see what the BUN is. And you also want a TSH. When you move away from pathology of these organs, and by the way, let me just pause for a second. Even if we see pathology of one of these organs, we got to determine why. But there's no reason for us to dive into the various causes of pathology of those three organs. But then other notorious diseases associated with an itch include HIV and also liquid malignancies, specifically lymphoma and myeloproliferative neoplasms can have sort of a refractory itch. So I'm right there with you, Robbie. I think the chronicity, I think the description of the rash is a sequela of this person really scratching themselves. And so now we got to dive internally to see whether there's pathology of one of those three organs or if there's some occult malignancy prioritizing liquid cancer that might be at play here. Anything else to add, Robbie, before we get some more data?
Speaking of poetry, you have to dive into the body. I absolutely love that.
I was thinking about the river of blood.
Amazing. I hope
You
you're
gotta
not
just dive in.
Yep. Heck yeah. All right, Andrea, back to you.
So it might help. In the review of systems, the patient says that for 1 week, the patient's endorsing intermittent constipation, light-colored floating stools, and darkening of the urine. His wife says that his skin has been turning yellow recently. And there's no other review of symptoms that is interesting. His past medical history, he has a history of hypertension, obstructive sleep apnea, hyperlipidemia, prediabetes, and benign prostatic hypertrophy. His medications, he's on lisinopril, tamsulosin, with no recent changes. On his family history, his mother had history of mild lymphoma, and his social history, he's retired and lives with his wife. Former tobacco use, 10 packs a year. Currently, he drinks alcohol socially, 1 beer per week, and denies recreational drugs. That's the end of the third quote.
Wonderful. So I am going to make a point as to why this patient has direct hyperbilirubinemia, and then I'm going to pass the mic to Robbie. You know what's so fascinating about this case, Andrea and Robbie, is that the patient's chief concern is an itch, but then we find, these quite pivoting findings on review of systems, meaning the jaundice. So if you're a problem solver, like all of you are, which one would you prioritize, the pruritus or the jaundice? 100% you would prioritize the jaundice, because whatever's causing the jaundice is causing the pruritus. So you see how our framework has changed, how the what isn't the pruritus anymore. Right now, the what is the jaundice, and then lower on that list of problems is the pruritus, because there's some causes of jaundice that are more likely to cause pruritus. And for example, primary biliary cholangitis. So now I want to make an argument why this is direct hyperbilirubinemia and then pass the mic to Robbie. When you're approaching jaundice, your mind should convert that to hyperbilirubinemia. And then the main branch point is it direct or is it indirect? Even if we didn't have the color of the stool, I would still say this is probably direct, because in order for bilirubin to give that dark color to the urine, it has to be direct, which is water soluble, unlike indirect, to actually make its way to the kidney. And then another reason that we prioritize direct hyperbilirubinemia rather than indirect is the acoloid stools, like the lack of coloration in the stools, meaning something's obstructing the secretion of bilirubin within the intestines to give the stool the color that it normally carries. So 2 reasons why this is direct hyperbilirubinemia is a dark urine, and the opposite, the light colored stools. Mike, to you, my friend.
Oh, I think that's absolutely superb. I especially love the emphasis that now the problem we're solving is a 61-year-old man with subacute direct hyperbilirubinemia. And that is an easier problem to solve than where we were in the get-go. And that's easier because we can lay it on this visual map, which I'm going to show you in a moment. And that visual map is now, we know it's not just jaundice, we know it's direct bilirubin. And now the next key question is the site of pathology in the liver itself, or is it in the extrahepatic biliary tree? And only when we make that this next leap should we expand into the subdifferential diagnosis. So what's the point that I'm going to try to make here is to argue for you to not be thinking about what the answer is here. I think that is not the most efficient use of your cognitive resources. What you should be trying to do is you went from blue, direct bilirubin, and now you have to answer the red. Is it intra or post? And only after that do you dive into the purple. If you're trying to be cognizant of the mental load that you need to carry, considering the subdifferential diagnosis now is way too soon. So the key question is, how do we differentiate between post-hepatic and intrahepatic disease? And that is through imaging. We can see the post-hepatic diseases because either they are visually macroscopically apparent themselves, like a pancreatic cancer, or that even though they are not apparent, they cause biliary dilation. And so by inference, we know they're there. So the next key question is, what does the imaging look like for this patient? And does it show duct dilation or not? If there is no duct dilation, the disease is intrahepatic. And the question will be, what kind of imaging will we use to make that determination? And the best imaging is an ERCP. The least good imaging is an ultrasound. CT and MRI are in between those two things. How can you make an educated guess, even before you get imaging, as to where the disease lies? That's when you have to look at the liver enzymes. The higher the AST and the higher the ALT in a patient with bilirubin, the higher the probability the disease is in the liver, because there are no AST and ALT liver enzymes in the extrahepatic biliary tree. So it's a game of probability. If the AST, ALT are super high and there's no biliary dilation on imaging, intrahepatic. If the AST and ALT are low and there's a lot of biliary dilation on the imaging, extrahepatic. And then real life clinical medicine will humble you with variations of each of those two things. So 2 pieces of advice. Re-emphasize what Prof. Rest taught us. This case is a jaundice, pruritus equals jaundice equals direct hyperbilirubinemia case. Don't look at the purple yet. The key is the red. And if you are like 10% of the population may struggle with color detection and are colorblind, I apologize in advance. It's intrahepatic or posthepatic. That's the key question now. I wouldn't be thinking about anything else. AST and imaging will help us answer that. AST, ALT / imaging will help us make progress next. All right, Andrea, back to you.
You guys are amazing. So I'm gonna give you the physical exam and lab work, and it's gonna be all clear. On physical exam, His vital signs are blood pressure of 157/73, heart rate of 59, oral temperature of 97 degrees Fahrenheit, saturation of room air 96, BMI of 38. On head exam, pupils are equal, round, reactive to light, extraocular muscles are intact, and conjunctival icterus is present. On skin exam, there is jaundice, with multiple scoriations on the chest wall, bilateral upper extremities and lower extremities, no hives, no lesions. The abdomen is soft, tender to palpation in the right upper quadrant and left lower quadrant, no distension, normal active bowel sounds, no masses, no hepatomegaly, negative Murphy signs. On labs, CBC, white blood count 6.2, hemoglobin 7.2, hematocrit 46, platelets 290, sodium 135, potassium 4.7, chloride 99, CO2 of 18, BUN of 18, creatinine of 1.3, glucose 110, and that's the important part, AST of 54, ALT of 51, total bilirubin of 6, and direct bilirubin of 3.8. That's the nice part. Alkaline phosphatase is 329, which is high. And urinalysis, there's no blood in the urine. And urobilinogen of 4, which is elevated. No CAS, nitrate is negative. I think it might help.
Andrea, I think you're presenting this case so well. I especially love the addition of your own twist about where things may help. I think that's a really nice personal touch. I will leave the liver enzymes for resident digest and tell you the one thing I was really paying attention. The one acute, whenever somebody comes in with a chronic disease, you usually have just as much time to figure it out. But that may not be the case with somebody who is jaundiced. And somebody who is jaundiced, your priorities are to rule out 3 things: acute liver failure, massive hemolysis, and cholangitis. And so the rest of the labs help us make those much less likely. Direct hyperbilirubinemia and a normal hemoglobin make hemolysis much less likely. The absence of fever and leukocytosis make cholangitis less likely. And the normal coagulation parameters here and the normal liver enzymes, AST and ALT, make acute liver failure less likely. So I was actually mostly listening for those as the person who's first seeing the patient. And now you can breathe, take your time. There's no acute liver failure, there's no hemolysis, and there's no cholangitis. And now we can slowly digest the liver enzymes. And I'll pass the mic to Prof. Rez as he slowly digests his croissant and these liver enzymes.
Question, Andre, can you tell us again, what was the hemoglobin?
Hemoglobin of 17.2.
17.2. Wow.
No, 16. I'm sorry, 16.2.
Oh, 16.2. Okay, very good. Because I'll just start right away talking about the hemoglobin, because remember in alcohol 1, we said some myeloproliferative neoplasms can be associated with pruritus. And so when you see a high hemoglobin, automatically you start thinking about polycythemia vera, but you have to be cautious there. In polycythemia vera is a myeloproliferative neoplasm, and oftentimes you'll see an elevation in the platelet count. You'll also see an elevation in the white blood cell count, and specifically the basophil is a clue to myeloproliferative neoplasms. In this context, the hemoglobin being 16.2 is more likely hemoconcentration. And before you diagnose anyone with a rare cause like P. vera, make sure there's not a secondary cause of polycythemia like obstructive sleep apnea, COPD, or smoking. And plus, it'd be hard to connect the P. vera to the jaundice. So I'm going to assume that that relative polycythemia is from hemoconcentration because the patient's just not feeling well. And I expect those cell lines to come down with IV fluids. So now let's go focus on the rest of the chemistry test. One, the creatinine has grabbed my attention as well. It's 1.3. This patient is 61. We don't know what their muscle mass is. And the question becomes, is the kidney here a bystander? The same way you get hemoconcentration, are they a bit hypovolemic, leading to prerenal azotemia and acute kidney injury? So I'll be tracking the creatinine, but it's not where I'm gonna put the majority of the cognitive effort. Really, I think Robbie hit the nail on the head that we need to analyze the liver chemistry test to see if we can make more progress, where Robbie showed us that beautiful diagram of whether it's within the liver or outside the liver. And remember what he said. He said, if we're within the liver, if you have a high AST and a high ALT, it's more likely to suggest that there is some liver pathology without being able to completely rule out extrahepatic pathology. But here, what we see is a primarily elevated alk phos. So we know that this patient has cholestasis. This patient has cholestasis. And by the way, bilirubin isn't what causes the itch. A lot of people can have jaundice with zero itch. It's really the bile salts that start to deposit within the skin, activating those itch receptors that fire to the brain to give the sensation of pruritus, where then the patient scratches themselves. So the alk phos being elevated, we established cholestasis. And if you look at the bilirubin, in order for us to categorize this as primarily indirect, we need the majority to be indirect hyperbilirubinemia. But here we see that the majority is direct. So we framed this problem correctly, direct hyperbilirubinemia. So where do we go here? What's next for us? The next step is to still rule out or evaluate for extrahepatic pathology, extrahepatic biliary obstruction. So how can we do this? There's a few ways. You can do an ultrasound, you can do a CT scan, you can do an MRCP, you can do an ERCP. And the order I said those tests are the degrees of, in order of sensitivity, meaning that the MRCP is the most sensitive. I'm sorry, the ERCP, then the MRCP, then the CT scan, then the ultrasound. In this patient, I mean, you could start with an ultrasound to just see if you see anything obvious and if there's any biliary dilation, and then go from there. But a normal ultrasound, a normal CT scan wouldn't prevent me from wanting to get an MRCP. So where are we now, folks? 61, direct hyperbilirubinemia, evidence of cholestasis, or jaw is to determine, is this intrahepatic or is it extrahepatic? And how are we going to make that determination? It's going to be some form of imaging, and depending on what's accessible to those specific providers, it's what's going to happen next. So let's wait for the imaging, and then we go from there to share our DBX. Yeah.
Okay, on imaging, the right upper quadrant ultrasound showed an intra and extrahepatic biliary dilation with questionable stone in the distal common bile duct measuring 18 millimeters, fatty infiltration of the liver, dilated gallbladder containing a sludge, no gallbladder wall thickening, or pericholecystic fluid. On CT scan of abdomen, there was biliary dilation, intra and extrahepatic, papering at the level of the pancreatic head, non-radiopaque stone, not entirely excluded, no pancreatic head mass, there was an indeterminate lesion within the right lobe of the liver, measuring 2.5 for 1.8 centimeters. And there was new lab, TSH of 2.7, HIV screening was negative, acute hepatitis panel was negative, lipase, IgG4 levels, and CEA within normal limits, and CA 19.9 was 125, which is high. And that's it.
Very, very helpful. And Robbie, I'm curious, and I don't know the answer to this, but like with the acolic stools, in my experience, both in reading cases and what I've seen, it's usually when there's some form of extrahepatic obstruction. So I don't know if that could have been a clue that we were going to deal with some extra. I would love to hear from the audience in the chat, and also from you, Robbie, if that's been your experience as well, that maybe that should prioritize extrahepatic obstruction as opposed to intrahepatic cholestasis. This is actually a very fun aliquot to discuss, but also sort of a sad aliquot for the patient, because we're not sure what is going on yet at that pancreatic head that's causing the obstruction. And why I say this is interesting is because we have a lesion in the liver, then we have intrahepatic, and we have extrahepatic dilation, and we have no mass detected on CT scan, and we have a high CA19-9. So the question is, what's signal, what's noise? Well, we know in order, if you have extrahepatic dilation, then you know that there's an extrahepatic obstruction, and then that pressure will build up and cause the intrahepatic biliary ducts to dilate as well. So the lesion isn't intrahepatic, it's extrahepatic. So what to do with this liver mass? The liver mass is not causing the biliary dilation, but the question becomes is, do you have something starting in the pancreatic head that now through the portal circulation or through the biliary ducts will spread to the liver, leading to additional pathology? For example, cancer, like pancreatic adenocarcinoma, cholangiocarcinoma, duodenal or ampullary cancer that has now spread? Or is the liver lesion totally benign and not, is just a benign, adenoma? Is a benign hemangioma? Who knows? How can we make more progress? Honestly, in this specific case, I do think, Robbie, they need to do an ERCP and evaluate what's happening, because even the normal IgG level does not rule out IgG4 related disease, which is a lymphoplasmacytic infiltration of tissue. But I think what we need to do is an MRCP. This will allow us to, and an MRI of the liver, this will better allow us to evaluate the mass, to evaluate what's happening within the biliary system, then to follow up with an ERCP and tissue sample. I would love to hear from you, Robbie, how you're analyzing this case.
Yeah, no, I absolutely love it. I have nothing to add, and I will just say that that analysis is so sharp and to the point. And I love what you started. You're like, this is not a great aliquot for the patient, and I think that just to put light to that, I think often when you are in this situation, it really is a tension between stone and mass, and that tension is what's causing the obstruction, and you don't really know until you look at what that is through ERCP. And the reason that stone is a little bit less likely in this instance is the stone doesn't usually cause this degree of hyperbilirubinemia. A stone, you'll see like 1% of stones cause a bili of greater than 10, and the higher the bili, the less likely it is to be stone disease. The other thing that stones are more common to do is they usually cause pain, and the absence of pain is an argument against stone. And then finally, stones are usually complicated by cholangitis. And I'll skip over the answers why. So all things are going against stone here. It's painless, the bili is pretty high, and there's no cholangitis. But here's the problem. Stones are way more common than cancer. And so the base rate would prioritize a stone, and the probability of a stone only goes down from its initial high rate. And so cancer moves up, and cancer's morbidity drives what Reza started to say, which is this is a pretty sad aliquot for the patient. And I would just say that the range of cancers in this area are very long. pancreatic cancer is the most famous, but you can get ampullary cancer, as Reza said. You can also get cholangiocarcinoma. You can get lymphoma. You can get neuroendocrine tumors of the pancreas. So the probability of cancer is still pancreatic, but no, the list is actually pretty long. And I'll just say, close attention to the radiology can be very helpful. The involvement of the dilation of the gallbladder is very helpful. The fact that the gallbladder is dilated tells you that the pathology of obstruction is distal to the gallbladder. Now, why is that important? It's important because cholangiocarcinomas usually arise at the juncture of the hepatic ducts, at the common hepatic duct. That's called a Klatskin tumor. It's about 50% of cholangiomas come there. So if you see biliary dilation without gallbladder dilation, that localizes the lesion to the common hepatic duct, not the common bile duct, which would make the probability of cholangiocarcinoma much more likely. So I'll explain that again. I loved Andrea's emphasis of the gallbladder dilation. The gallbladder being big tells you that the lesion is in the common bile duct. If the gallbladder is not big, that tells you that the lesion must be proximal to where the common bile duct is, because if it's a common bile duct, it'll also dilate the gallbladder. So if the gallbladder is not involved, it tells you that the lesion is at the common hepatic duct, because both intrahepatic ducts are dilated. And the most common lesion at the common hepatic duct is a cholangiocarcinoma. It's known as a Klatskin's tumor. So, and this is just an example of the nuances that radiology can help you with. But no matter what, these are all just nuances. I completely agree with Prof. Rez. We need to take a look, and the best way to take a look is through an ERCP. All right, Andrea, back to you.
Okay, you guys are awesome. So the patient had an endoscopic retrograde cholangiopancreatography, it's so hard to say, ERCP, which revealed a malignant mid-CBC structure with proximal dilation. He had a sphincterotomy with stent placement and a biopsy. His biopsy revealed an adenocarcinoma consistent with extrahepatic cholangiocarcinoma of the biliary duct. The patient was referred to the medical oncology for chemotherapy, and that's it. You guys are awesome.
Thank you so much, Andrea. We're not awesome. You're awesome. Thanks for bringing this case and presenting it. And I'm currently learning French. If I could speak, 100 as good as you speak English, if I could speak French, I would be such a happy person. And the fact is, the ERCP, I never pronounce the entire, acronym because it's so hard to pronounce. But anyways, thank you so much for presenting this case. I'm interested to know what happened to the patient. But if I just step back and do a quick cognitive autopsy, I think that the way that this case unfolded, although it started with pruritus, what was most concerning for the patient, we then quickly learned that there's jaundice. The next step is it direct or indirect? And that acholic stool in the dark urine told us that it was direct. And then I loved Robbie's point about the biliary dilation and where to expect the lesion if the gallbladder is distended as well. I'll leave it at that and pass the mic to my mathematician.
No, thank you, Red. It's very, very kind. It's always there's always so much learning in these cases. And I think that, honestly, every time we're done, what I do in my head is I'm like, okay, where did we start and where did we end? Just for practice. And it was like pruritus, pruritus without a rash, jaundice, direct bilirubin, extrahepatic, ERCP, cholangiocarcinoma. And you could try to iron out that entire pathway about how you can get there more and more efficiently. And I think that this case is a great way for you to practice going through that more and more and more efficiently. And I think, were there any clues to prioritize cholangiocarcinoma over the other diagnoses? I can't think of any. I think pancreatic cancer could have gone to the liver just as easily. And so that'll be a source of maybe more reflection for me. I just emphasize for those of you who are learning about tumor markers that the tumor marker here is not super helpful. Tumor markers are associated with elevations in benign diagnoses. So it is helpful now because you can track it after you address the cholangio and see if it goes down, and then use it as a marker of recurrence. But the tumor marker doesn't help you too much in diagnosis, unfortunately. But my biggest takeaway is honestly just how humbled I am that Andrea can come in here not with English not her first language, share the anxiety of presenting, and just do such a marvelous job. I hope we'll see you around more and more often. And I'm also excited because we have our Portuguese duo, Catarina, who's scribed, and Laura, who's doing teaching points to take us home.
Je ne sais pas, Robbie.
What?
Je ne sais pas.
Je ne sais pas. He does not know.
No, I don't know. Je ne sais pas.
Is that it?
Anyways.
Was that your interjection?
I wanted to. I should never interject in French.
I was like,
I have nothing else to say.
Je ne sais pas what? What don't you know? All right, great. Is that something you learned today, learning French?
No, I learned that a week ago and I keep practicing it.
Okay, good. Amazing. Well, I hope Laura can sneak that into the teaching points somehow. I think we should add a French lesson to the teaching points every single time Reza's here. All right, Laura, Mike.
I would add it, but I don't know how to write that. Je ne sais pas. I don't know how to write that, but yeah, I've learned it. Hi guys, I'm Laura, and let's go with the teaching points. Andrea, thank you so much for coming today. Your case was amazing and beautiful presentation. And thank you, Robbie and Reza, as always, for being brilliant. So we started with how to approach pruritus. So we should think about tempo. So is it acute or chronic? And we saw that it was a chronic complaint. So then we have to think, is it a skin problem or an internal problem? So we should pay attention to the words itch or rash. So is it an itch that rashes or a rash that itches? And most common causes of itching would be dried skin, medications, neurologic causes, and psychiatric causes. Also, we could think about other organs that could be involved. So the liver, the kidney, and the thyroid. And some fancy causes would be HIV and liquid malignancies, as Reza told us. So we found out that the patient had jaundice. So now the approach is different because now it is jaundice and pruritus. And we could think about primary biliary cholangitis, for example. And so the direct bilirubin, we thought that the bilirubin would be high because of the direct bilirubin, because of the dark urine and the alcoholic stools. And we should evaluate the liver enzymes. So if there is higher AST and ALT, the disease would probably be in the liver. And if there is a dilation of the biliary tree and low AST and ALT, then it should be a post-hepatic disease. And here I attached the jaundice thought train schema that is on the website, so you can check it out later. And then Robbie told us to exclude emergencies, so acute liver failure and massive hemolysis and cholangitis. And he told us about the difference between stone and mass. And that is that the stone doesn't usually cause a super high bilirubin, and there is usually pain involved and usually complicated. It is usually complicated by cholangitis. So this would probably be a mass, which it was, cholangiocarcinoma that usually arises from common hepatic ducts. So that's that. Thank you so much for today. It was amazing.
Oh, I still can't find the unmute button. That was absolutely amazing. Thank you for that walkthrough, Laura. Really, really nice. Rafa, do you want to, I know you just typed it in the chat, but maybe for folks who will listen later on YouTube, do you want to share your announcement? If you can't, that's okay. I'm happy to read your words, but since it's your work, go for it.
Yeah, so tomorrow we have a global VMR with Dr. Roma Mahesh. I'm sorry for the motorcycle, by the way. And Sunday we don't have students morning report, but on Monday we have Himonks specialty VMR with Dr. Sam and Dr. Lara from your CSF. They'll be discussing a case presented by our dear friend Franco. So thank you, everyone.
Amazing. A lot coming your way. Hope to see you all live. Bye.